Good afternoon. In this presentation, I will demonstrate and assess three manual muscle tests, which focus on muscles within the lower limb, the hip, knee, and ankle joints. Now, before commencing any form of manual testing or practice, it's essential as a practitioner that I obtain informed consent to uphold ethical practice and to ensure client safety. This step not only ensures I uphold my professional standards, but it also helps to establish a rapport with the client and build trust and comfort throughout our time together. So I'll just play a short video for that. So as you can see in that video, I've introduced myself to the client. I've clearly outlined the purpose of the assessment, and they are comfortable for me to proceed. Again, I have maintained communication, ensured her consent, and she's comfortable. Now, once this part is complete, I move on to a warm up. So, just on that as well, you can see I've before starting with the tests, I asked the client to inform me of any injury or numbness in any of these regions that we'll test. That's really important to understand because we don't want to inflict any more injury on the client. And as you've seen in the video, I've chosen not to test that left knee because the client um, informs me that she has some pain there and over a 3 out of 10. So that's a really important part of pre-screening. Cool. Now, as I said, before beginning any muscle tests, I conduct a brief warm up with the client. Um, a warm up is really important before these kinds of tests because it prepares the body for movement. It promotes nice, smooth joint movement in those tests, and it supports more accurate and reliable assessment outcomes. And this is supported by Clarkson in 2020 as well. Now, I'll play this video shortly, but for the warm up, I guide the client through a series of light joint mobility and dynamic stretching movements, which focus on the hip, knee, and ankle area. As I said, this gentle preparation helps to increase the blood circulation to their muscles. It'll enhance the range of movement, and importantly, it reduces the risk of injury, as explored by Reese and Bandy in 2023. Now, these joints will target the movements I'm assessing, so hip abduction and adduction in the frontal plane, that knee flexion and extension in the knee joint and surrounding muscles, and that ankle flexion with those rotational movements. Each exercise incorporates motion through different anatomical planes and prepares the body for those specific actions that will undergo in the test. So I'll just play this video for you. Okay, so as you can see with the warm up, I have given the client clear instructions as to what I expect or want from the test and made sure they understand and cooperate. Throughout this warm up, I've also maintained my communication, checking in to see how the client responds to each stimulus of the warm up and just confirming that everything's okay, especially in that left knee. Now, I've also just said to outline any safety reminders to avoid abrupt force, anything that causes injury or anything like that. Okay, so I'll now transition to this next slide. So, bear with me. So here is the first test. So once those important steps of introducing myself to the client, establishing rapport and obtaining that consent, I'm now ready to proceed with the testing. The video on this slide demonstrates how to perform an adductor muscle test, which I'll play now. So as you can see in that video, I've maintained that ongoing and consistent communication, getting feedback from the client to how she feels. Now, so that test examined the strength of the hip adductor muscles, those muscles in the midline, the medial rather, region of that thigh. Now, this part of the presentation will particularly focus on the adductor magnus muscle, which is the largest and most powerful of that adductor group, as explained by Kendall in 2022. Now, the adductor magnus is located, as I said, along that inner region of the thigh, and it spans from the inferior pubic ramus and ischial tuberosity at the bottom of the pelvis area to the linea aspera and adductor tubercle. That broad structure, so allows the muscle to act primarily as a hip adductor and also assists in some rotation and extension. Now, when this muscle is activated, it produces concentric hip adduction, which draws the leg towards the midline of the body through in its shortened movement. This coordinated movement also allows pelvic stability and control while standing, while walking, when we change direction. To provide a bit of a sporting example, in a sports context, the adductor magnus plays a key role during movements such as a soccer pass. So as that player swings their leg across the body to direct the pass, that adductor magnus contracts concentrically. And as we pass, you can imagine that pulls the leg towards the midline through that frontal plane. Now, this highlights the importance of the strength of the highlights the importance of hip strength and stability during this lateral movement. And it's the same pattern as you saw I was testing in the video. Now, to accurately assess the adductors, you saw I put the client in a position which allowed controlled isolation of the hip through that frontal plane, and with the support of my hand on that upper leg, I reduced any activation of surrounding muscles that may compensate for any weakness that the client may have, which we don't want. We really want to isolate that muscle to get a true understanding of its strength. Now, as you saw, the client is in a position lying on their side with the test limb underneath against the bench surface, and the upper leg is supported by myself. As this position allows that, again, stability to perform that desired hip abduction. And as the examiner, I stand behind, maintaining control and applying that stabilizing pressure to prevent that unwanted hip rotation and flexion. And this is reinforced by Daniels and Worthington in 2013 from their book. Now, as I said in that video, it's really important that resistance is applied in the right areas. So I applied resistance to that medial part of the femur, just above the knee. And you always want to do it in the opposing direction of the client's movement. Now, correct hand placement is essential, as applying too much pressure on the knee joint may increase stress on that joint and cause injury, which we really don't want. Maintaining continual dialogue throughout this test is really good practice. Now, the attention shifts to the knee joint in the next slide. Now, to evaluate the strength and function of the quadriceps, specifically, again, in this presentation, the rectus femoris, which is responsible for knee extension and support. I'll just play the video of this test so you can get an understanding of what I will be talking about next. Cool. So as explained by Kendall in 2022, the rectus femoris, which is in that middle region of her thigh, is one of 4 muscles that make up the quadriceps group, and they're renowned for their strength, power, and their stability of the knee. Now, the rectus femoris is quite a unique muscle because, as you can see, it originates at the anterior inferior iliac region of the spine, of the pelvis, and it inserts at the patellar tendon. So it essentially is involved in hip flexion and knee extension. As I said, it's located on that anterior region of the thigh. So the front of the thigh works across the tibiofemoral joint in the knee, which is a hinge joint. So it allows for, again, that flexion and extension in one movement plane, the sagittal plane. Now, when it's activated, this muscle, it concentrically contracts to allow knee extension, and then eccentrically, so at its lengthened position, to control knee flexion, allowing like a nice fluid, smooth movement, as we saw from the client in the video. Now, again, this action is commonly seen in sports such as AFL. The rectus femoris is heavily engaged during that kicking action, where, like a fulcrum, where you really need that efficient movement between knee flexion and extension. As the player begins that kicking motion, their knee flexes and lengthening that rectus femoris muscle under the tension in an eccentric contraction. Now, this controls the stability of the knee and stores that energy for like a nice snap when making ball contact. So as the leg moves through that sagittal plane, the rectus femoris and other quad muscles concentrically contract, so in a shortened position to extend the knee and exert that force to strike the ball. This is a powerful and controlled movement, and it highlights the role of the quadriceps in producing force and stability for the knee. Now, that same mechanism was tested during that strength assessment, where you saw I isolated the quad muscles to determine their ability to action and control knee extension when applied resistance is supported by Janda in 2013. Now, as you saw in the video, to accurately assess the rectus femoris and other quadricep muscle strength, the client was positioned in a nice upright position with their hips flexed and knees at about 90 degrees. This position will isolate that rectus femoris whilst reducing the compensation of surrounding muscles. Sometimes you'll see tight hamstrings, hips, other things that may influence how smoothly you can assess that strength. Now, you'll see as the examiner, I again ask for consent, inform the client of what I'm going to do. I stabilize the proximal thigh with one hand to prevent any hip movement, and while the other hand applies resistance at the distal tibia, so the end part furthest from the insertion, in a downwards line of knee flexion. As I said earlier, you want to oppose the force you're trying to test to get a really good understanding of the strength. And then I instructed the client to extend their knee slowly, making sure that they didn't experience any pain greater than 3 out of 10, and just maintain control through that movement, which they were able to do. Again, in all testing, it's really important to have correct hand placement and setup. Now, I don't want to place my hand too hard on the ankle there when applying any pressure, or too much, because that will place stress on their patellofemoral joint and that patellar tendon, which in that flexion or flexing motion really absorbs a lot of that tensile load through that tendon and can cause some pain, particularly why we didn't test her left leg. And throughout that test, you're always looking to observe for any compensatory movements in the hip flexors, hamstrings, or surrounding muscles that may allude to any quadriceps weakness, imbalance, or if it was significant pain or compensation, there might be a mechanical issue. And then again, I'm consistent with my communication, my expectations, and verbal cues to aid the client's comfort and accurate testing. Now, maintaining that anterior focus throughout the lower limb testing, the next strength assessment targets the tibialis anterior muscle in the ankle joint. Cool. I'll just play this video. Cool. So, as its name suggests, the tibialis anterior is located along that anterior aspect of the lower leg, as you can see in this diagram here. Now, it originates at the lateral condyle of the tibia, which is up here in the diagram to that outer side of the joint. It traces down that shin almost like a cross, wraps around the front of the tibia, as you can see. And then it inserts at the medial cuneiform, which is the middle part of the ankle just down there, and onto the first metatarsal of the foot, or ankle joint rather. And that information is supported by Cutter and Kevorkian in 1999. Now, the tibialis anterior produces dorsiflexion, which is the concentric action to lift the toes towards the sky, or towards the shin rather, and then also inversion, so moving towards the midline of that body. Yeah, towards the midline of the body. It also helps in eccentric contraction to control plantar flexion, so pointing the toes downwards. This is particularly when, like in foot landing, when we're running and whatnot. This action also happens in walking and running to stabilize the ankle during dynamic movement. Now, again, to relate this to a physical example of how the tibialis anterior functions in sport, think about how it activates during running and jumping, notably in dynamic sports like basketball, where they're springing to dunk, to cut into lanes, shoot even. Now, an example of this, as I said, was when an athlete attempts to dunk. The tibialis anterior plays a vital role in both initiating that jump and absorbing the landing. As the athlete would prepare to take off, that muscle concentrically contracts, so it's in its shortened range of motion, generating that force almost like a coil, and then allowing that dorsiflexion of the ankle joint, and then lifting the toes is that explosive launch towards the rim and into plantar flexion in that eccentric lengthening of the muscle, and absorbing that impact when you come down, preventing the foot from forcefully striking the court and reducing any chance of injury. Now, this muscle enables very efficient energy transfer through that lower limb. It helps to stabilize the ankle and maintain balance. It's quite an important muscle in that lower limb region, but often overlooked. Now, as explained by Kendall in 2022, to manually test the strength of the tibialis anterior, similar to the quads, the client is seated on the bench in an upright position with their knees flexed at roughly 90 degrees. Again, this allows freedom of that ankle joint to move around and isolate that tibialis anterior and restrict any other muscles from getting involved. We always want to put the client in the best position possible to isolate the particular muscle we're assessing. Now, as the examiner, you saw I stabilized that distal tibia with one hand and cupped the other in that dorsal region of the foot over the metatarsals, and cupped the medial region of the foot to direct plantar flexion and eversion, which is the outward movement. As we know, we want to do the opposing movement to get that desired strength assessment. Again, it's really important to establish hand placement and correct technique to avoid pressure being applied too close to the ankle joint, or for any joint for that matter. As we know, it can cause a lot of discomfort. It can even alter the movement patterns of the client or the muscle and place significant stress on surrounding joints. Now, as this part of the presentation draws to a close, it's important to address how we interpret these muscle tests. Now, they provide a really valuable insight to the client's overall muscular strength, their balance, and their ability to control that limb. or in this instance, that lower limb. Now, as we were trying to establish with the client, each assessment, we're looking for a strong pain-free contraction. That's the goal, as that reflects the most optimal muscle function. It also reinforces effective neural activation, where the brain, the nervous system, and the muscles are all working in sync to tell the brain, sending signals to the muscle to activate. If sometimes there's a block with an injury or whatever, that is going to not necessarily work, almost like a flickering light. The muscle won't quite activate. And then finally, joint stability. Opposingly, a weak or painful response can suggest any potential muscular imbalance. It can, in other cases, fatigue or strain, which reveals underlying dysfunction or injury risk, as supported by Cuthbert and Goodhart in 2007. Now, in the adductor test, a poor contraction or discomfort may highlight an adductor strain or pelvic instability, where typically you'll see compensation from the hip flexors and hamstrings, which will assist that adduction. And then during the quadriceps assessment, weakness presents as limited ability to perform that knee extension or difficulty maintaining alignment, suggesting there's some patellofemoral dysfunction or rectus femoris tightness, strain, or fatigue. That's why we didn't test the client's left knee. They indicated in that patellofemoral region, which is where the patella tracks in the knee joint, that they had some tightness and pain. So we don't want to aggravate that by forcing that muscle or that joint into any kind of test. And then in the tibialis anterior, an inability to perform that dorsiflexion or inversion may highlight, again, weakness, tightness, or a deeper issue in that anterior compartment. Now, across all tests, as a practitioner, you really want to perform bilateral comparison. It's really crucial in identifying any asymmetry, which is differences between the limbs and the muscles. And this is really supported by Bishop in 2023. Now, minor strength differences on the dominant and non-dominant side are to be somewhat expected, but any obvious discrepancies indicate that compensatory pattern, and potentially some adaptations from older injuries where you've learned how to deal with what was affecting you, and that muscle is now not ideally, or that joint operating as it should. Now, there is external influences as well, as we touched on, with fatigue, effort. Sometimes there's that anxiety when you come in and you're being tested, which is why it's important to establish a rapport with that client. And then sometimes there is examiner technique error that can affect performance, reinforcing that need for that really consistent positioning, communication of what we expect from the client, and that resistance application as well. So making sure it's in the right spot. Despite targeting different muscle groups, all three tests do share the same foundational principles of requiring muscle isolation, stabilization, and controlled movement within that anatomical plane for the most accurate strength assessment. That goes for muscles and joints across the whole body. Now, as the examiner, it's really important, as I've touched on numerous times, that I'm consistent in my positioning of hands, and resistance positioning, and communicating to clients to maintain controllable variables and reduce any activation from any neighboring muscles. As we said, a strong pain-free contraction is the goal. That really concludes part one of the presentation. Yeah, this series, as I've touched on, this series of manual muscle tests for the hip adductors, the quadriceps, and the tibialis anterior has demonstrated how each muscle contributes to strength, control, and movement in the lower limb. These tests allow us to assess how, if effectively, the isolated muscles contract and move within their range, and it provides those cues that you're also looking for as the practitioner of any weakness, imbalance, or compensation from other muscles. We've shown a strong and pain-free contraction rather, indicates proper activation and control, and that weakness is somewhat of an alarm. We know that comparing both limbs bilaterally is excellent practice as it gives a thorough assessment and we can detect any adaptations. Thank you for watching part 1 of my presentation. Now for part 2, I will discuss the hip and knee complexes that are associated with manual muscle testing that I performed as part of worksheet 9. Now, like part 1, the aim of these assessments are to evaluate strength, stability, and control of key muscles in that lower limb group. Functionally, these muscles play a vital role in maintaining posture, balance, and optimal movement through the sagittal, frontal, and transverse planes, which allow that dynamic movement like walking, running, jumping that we see in all sports. Now, as you see in this knee and hip joint complex, the grading table, for lack of a better word, I conducted 13 manual muscle tests that I categorized into 6 groups that include the hip flexors and extensors, the hip adductors and abductors, and then the knee extensors and flexors. For each test, as I did in part 1, I focused on using accurate positioning, controlling that applied resistance, and providing clear communication with the client to ensure their comfort and safe and reliable results. Now, all testing, as I said, was conducted bilaterally to compare the strength between the limbs. And as shown on this slide, I used a 0 to 5 grading scale, 5 being full strength and 0 showing no contraction. As we know, bilateral testing supports accuracy and it helps identify any imbalance. And it's just really good to get good, reliable feedback from those muscles. Now, transitioning to the main part of part 2. So testing the hip joint can be complex. It's a ball and socket joint that allows vast movement through anatomical planes. The surrounding muscles enable flexion, extension, abduction, and adduction, providing mobility and stability, but at the cost of sometimes injury or lack of power. But having this hip and surrounding muscles functioning optimally is super important. So in the first test, the hip flexors were tested. Primarily the iliopsoas and sartorius muscles were tested to evaluate that strength and control of hip flexion in the sagittal plane. So hip flexion, like moving forward where your hips shorten in length. To do so, the client was seated upright with their knees flexed, a really familiar setup we know now. I stabilized their shoulder to just provide a bit of support and applied gentle resistance to that distal thigh to isolate the hip flexors, which lift the upper leg towards the torso and downwards, working eccentrically and concentrically, as we know. Same as always, a strong pain-free contraction with full range of motion was achieved, scoring a score of 5 bilaterally. Then moving on to the hip extensors. Now, these are primarily the glute maximus with some assistance from surrounding muscles. To test hip extension, the client lay prone, so on their anterior side facing downwards with their knee flexed at around 90 degrees at 90 degrees to minimize any hamstring involvement. And that isolates those gluteal muscles. I applied resistance to the distal part of the thigh. As always, we want that in the opposing direction. Now, when the muscles contract, they extend that hip, and eccentrically, they do the opposite to control hip flexion. Now, during the testing in the hip extensors, I'm looking for any pelvic rotation as a cue, which may indicate any weakness in the glute or hip flexors. These muscles are really big, so they generate a lot of power to propel movements. So it's really important to get a good idea of how they're functioning. In this instance, they both scored 5 bilaterally. Moving on to the hip abductors, and adductors. The gluteus maximus, medius, and minimus, and the TFL, the tensor fascia latae, are involved in hip abduction. Now, the latter three were tested to assess hip abduction strength and lateral stability, moving through that frontal plane side to side. Lying on their side again, the lower leg is flexed. However, the tested leg is on top, and you stabilize the pelvis. I apply the resistance to that lateral part of the thigh to push inwards, because we want to see how well that leg can move in abduction, so away from the midline of the body, where we get that really nice contraction from those big glute muscles. A strong and steady lift indicates that good lateral stability. And again, as you can saw back in that last slide, another score of 5 to each side with really solid contractions demonstrated. And then for the hip adductors, this involves those which I touched on earlier in part 1, the medial muscles. So the adductor longus, brevis, magnus, the gracilis, which is a really small, fine little muscle, and the pectineus, which trace that medial thigh. Now, these muscles were tested to assess hip adduction strength and then control in that frontal plane again. To determine their strength, as we know, the client is placed on their side lying with the test limb on the underhand side, on the underside, and the upper leg is supported by myself. And I apply resistance to that medial side to understand the strength. Now, what I observed in this one was, or what I was observing for, was any internal rotation that indicated some involvement of hip flexors and hamstrings, but that wasn't the case. Again, the client was really strong. They displayed a full range of motion, both scoring a 5 on either side. Now, moving to the next part, the knee flexors and extensors. In simpler terms, the hamstrings and the quadriceps groups. Now, the knee flexors are the hamstring group, including the popliteus, the semimembranosus, the semitendinosus, and then that bigger one, the biceps femoris, are all knee flexors. These were tested to assess knee flexion. So when in other tests, you want the knee flexion, essentially means knee at 90-degree angle, where the angle, for lack of a better word, shortens, which means these tests, as I said, the hamstring muscle flex or contract to flex the knee and aid hip extension, and they work eccentrically to stabilize the leg during different movements, particularly in running and jumping. When you imagine when your leg is stretched out, taking a stride, those hamstring muscles are in eccentric contraction, and then concentric when they pull back towards the body. So really, really important muscles, really crucial to function and stability of that lower leg. Now, during the testing, I got the client to lay in that prone position on their tummy with the knees flexed at around 50 to 70 degrees, and resistance was applied to that extension. So pushing down towards the bench to see how well that muscle, to see how strong that muscle is rather, Now, again, each muscle demonstrated a really strong and controlled contraction with full range of motion, scoring 5 bilaterally. And then moving on to the last one, the knee extensors. Now, I've touched on this earlier. The knee extensors are the quadricep group, which consist of that rectus femoris muscle, that big one in the middle that we spoke about, but then also the vastus lateralis, which is on the outer side, the vastus medialis, which is that nice teardrop kind of muscle you or people often refer to, and then the vastus intermedius, which is kind of wrapped underneath. Now, these tests assessed knee extension strength and control through the sagittal plane as well. Now, for these tests, the client is seated, as we know, in that upright position with the knees flexed at 90 degrees. On the right side, all 4 muscles demonstrated a really strong contraction, scoring a 5. But on that left side, as we know, I use the same client for these tests. There was a slight reduction, or there was no contraction at all due to that really significant knee pain. So he didn't score. This is likely linked to that recent injury they sustained, where and what is causing that pain is where the quadriceps have compensated for that knee weakness and instability, which is putting a lot of tension and strain on all sorts of muscles and cartilage. There's a fat pad in there as well. But overall, both sides still maintain good range of motion, which is what we want to see. Now, observations, implications, and or plan or integration for part 2. So during each test, I understood a strong and painless contraction signified that proper muscle function and activation that we're always looking for. I observed for any compensatory movement that would foreshadow any weakness, and also implemented that bilateral comparison that we know is really important for testing 2 limbs to observe any asymmetry, adaptations, or weaknesses. And then overall, reflecting on the testing, the focus, as always, is to understand the strength and control of these major muscle groups surrounding the hip and knee. The test targeted key movements that support the posture, balance, and dynamic movement of these important joints. Each motion was designed to isolate the specific testing controlled movements across the sagittal and frontal planes, so forward and backwards, left and right, allowing me to assess concentric and eccentric movement and getting good understanding of how everything's going. Overall, these tests, as we know, provide a really valuable insight into lower limb function, reinforcing the importance of correct positioning, technique, and skills. Thank you for watching part 2 of my presentation and my presentation overall.